Agora não estou a ouvir.
Não, estou a usar os dois. Ok, agora sim. Antes de mais. Okay, so good afternoon, everyone. Zé, can you hear me?
Oh, good. Yeah, all good.
So, José Luís Sandoval is a medical doctor, he's a Portuguese medical doctor. He's an oncologist. He's specialized in breast cancer at Geneva. And he's currently working still in the Institute Curie in Paris. He earned his PhD in breast cancer functional genomics in Cambridge. And he holds a master's in public health, which is quite a shift from his career, from the London School of Hygiene and Tropical Medicine. Sandoval has been researching in between clinical, translational, and public health arenas. He's very much focused on or interest on health inequalities. That's a part of his talk today. And yeah, so I would like to thank you, Zé, for being with us, for sharing your experience on this area and your views as a clinician, and then also as someone who thinks about the health of the population. For you all, enjoy. I hope you will like this seminar. Thank you.
So thank you very much, Teresa. Thank you for the invitation. Very proud to be here with you. I'll do it in English so that everyone can understand me. And quite honestly, I think that doing it in Portuguese would be harder for me at the moment because of all the technical terms. So as Teresa said, I'm a medical oncologist. I work in Geneva, do different things. Let me share my presentation so that I can start. Okay. Should be this one. Okay, can you see my slides?
Almost there. Yeah, we can see it.
Yeah, okay. So to start, now you can't. Sorry, don't know what happened. Just a second. You'll be fine now. Okay, so as in every talk, let me start by saying that I have some conflicts of interest, which are related to my oncology part of the job that I do in terms of organizing clinical trials, etc. But I have no conflicts of interest in the context of this talk. So what is the plan for what I would like to say and to discuss with you in the next half an hour or so? I would start with a very small introduction to health determinants and health inequalities, because I think you all know this by heart. Second, a very brief description of the Swiss healthcare system, because I think it's relevant to what I will show you afterwards. And as you will see, it differs greatly from what we have in Portugal and even in other places in Europe and further in other places. And also then I will go to the main topic of the health inequalities in the cancer care continuum with a particular focus on breast cancer, which is my area of clinical expertise. I will not do a thorough review of socioeconomic inequalities in cancer. I invite you to read this review that now is from 2016 from Coleman, very well known in the field. That is quite thorough and still up to date, but with a particular focus in survival and incidence of cancer. And I will try to go a bit beyond this in this talk, as you will see. To start, let's just talk a bit about health determinants and health inequalities. So as you know, health outcomes are shaped by several factors. Some factors are related to the individual, like age, gender, and of course, other constitutional factors, such as, I don't know, BRCA1 or 2 mutations, some genomic features. There is the individual lifestyle that shapes health. There is the social and community networks, also the living and working conditions with all its subtopics, and overall also the general socioeconomic, cultural, and environmental conditions. All these will concur and will impact on what we have in terms of health outcomes at the individual and at the populational level. Some of you may know, is just a representation of health inequalities that it's uh, frequently used, where we actually have life expectancy of birth in London depending on where we live and what is the proximity to different metro stations. And as you can see here in the middle, if you live at Oxford Circus, your life expectancy at birth is around 96. If you take the subway and you go to Angel, it's 79. So there's a 20-year life expectancy gap just because of living in Oxford Circus and Angel. Of course, this is related to what is the socioeconomic status of people that live in Oxford Circus versus Angel. Probably this has now changed with all the gentrification and all the changes that cities have been ongoing, but this is just representation of how marked these inequalities can be. If we stay in the UK, and as you may know, a big part of the literature in health inequalities come from studies in the UK. One example is this study of the association between healthy life expectancy and deprivation by region of residence. And if we take two regions, the most deprived, the least deprived, we see that there is a gap of 15 years of life expectancy in good health. And that's okay. We say 15 years, but is it all we need to say? I think not, and I will try to make my case. So if you just depict in a graph these two regions, you will see that this is exactly the same. We have the less deprived region with roughly 70 years of life expectancy in good health, and the most deprived region is right there on the corner with 54. And as you can understand, if you look at what happens between the two extremes, if we have something like this, we'd say, okay, so these are two outlier regions. What we need to go is to the most deprived region, do some targeted public health intervention, try to pull it up, and problem solved. Or the situation is different if what we have is actually a gradient. And in this case, just targeted interventions to the most deprived areas probably will not make a big difference in the context of the whole gradient. Unfortunately, as you may guess, this is artificial. It was just generated for me to put it in this graph, and this is the real data. So we see routinely, time after time, depending on which outcome you pick, this gradient. Also, the next question is, how do we measure this gradient? Do we just do a simple regression and put a line in the middle of all these points? That would be quite reductionist in a way, because as we know, each region has different weights, either size of population, either age structure that is different, gender structures that are different, differences in all the confounders that may be affecting the relationship between deprivation and life expectancy. As such, the best that we have to estimate these gradients is what we call indexes of inequality. It's just a fancy word to say that we have regression-based measures that try and see what is the difference between the two extremes, but take into account the intermediate groups and the relative sizes, and allow us, of course, because it's a regression-based measure, to adjust for other confounding factors. These measures can be expressed in absolute terms or in relative terms, and as you know, depending of which outcome and depending which message we'll try to pass, when we describe it in absolute or relative terms, it has different implications, different interpretations, and different impacts. For the purpose of this talk, I will represent inequalities using these indexes and in graphs that will look like this. So we have a line of non-inequality, and then we can have inequalities that are favorable or unfavorable to the lower socioeconomic groups. If we have an inequality that is detected, we'll see that the point estimate and the confidence interval does not comprise the line of non-inequality. And if there is no inequality, we'll see that this confidence interval should comprise this line. And this means that we have not detected a gradient of inequality. Okay, it can also be represented horizontally in some of the plots. Let me now go to the Swiss healthcare system. I think before we talk about the Swiss healthcare system, it's important to understand what is the Swiss political organization. It's quite particular. It's a confederation, which means that it's a very strong federalist country on which you have the federal government, you have the cantonal governments, and then you have the municipal, as they call the commune governments. And in some cases, you can have three parliaments. You can have the municipal parliament, the cantonal parliament, and the federal parliament. And this makes legislative and executive power to be distributed in three levels and the judiciary in two levels. And of course, as you can understand, this adds several layers of complexity. Also, for instance, to give an example, this is the current Swiss government, how it is organized. It's the Swiss government that is called the Federal Council. It's 7 people. They are elected from the parliament, but they are not elected all at the same time. They have a term of 4 years. And basically, when the term reaches the end, the place is either for re-election or for a new person, and whoever has the majority in the parliament will elect one person to the federal council. This makes that the government, which is these 7 people, are from different different parties, and the ministries rotate every year, and the office of president and vice president also rotates every year. And none of them, even though you may be called the president, is just a title. If you need to go and represent Switzerland, they don't have a vote of quality when they have to vote amongst the 7. So there's a majority always that will be established, and the president doesn't have a vote of quality. So it's quite particular. It allows for a very stable government with its good things and bad things, because you can understand that during COVID, uh, it was tough for things to happen because the governments were from different parties and everyone was trying to protect their interests. This, of course, this complexity of political organization is reflected in the healthcare system. This is, as you know, from the Healthcare Systems in Transition series, this is how the Swiss healthcare system is described. It's relatively complex, but I'll try to simplify it. On the top, you have the federal government, as I said, with the Federal Council, which is the government, and the assembly, which is the parliament. Inside the black square, we have what lies within the control, let's say the sphere of the insurance, and then you have the cantons. Inside this black rectangle, we have the insurers, which are all private, the sickness funds that compete amongst them. And we have the providers, where you have the physicians and the hospitals that negotiate directly with the insurers how much they should be paid for each service or act. And this is every, I don't know how many years, 3, 4 years, there's a round of negotiations between these two so that they can agree how much they should be paid. And then we have the patient that has the choice of which insurer he wants to contract, and also has the choice of the provider. And the provider has an obligation to treat, so they cannot discriminate. And besides that, you also have the cantonal governments that whose role can also be a regulation role, but mainly in terms of the providers. They are the ones that support the public hospitals, but they can also regulate access to private practice. For instance, in Geneva, since 2 years ago, everyone that finishes specialty cannot go to private practice unless there is a need and there is a waiting list. And this was instituted by the Geneva government. We can discuss why and what are the implications, but what I'm saying is that they still have considerable power at the cantonal level. So how would you describe the Swiss system? It's a consumer-driven healthcare system. So the patient has a choice of the insurer and of provider. It's government regulated. So the prices of the insurances and the deductibles are regulated by the government, and it achieves universal healthcare coverage with good outcomes. In practice, what does this mean? It means that, if you live in Switzerland, you arrive in Switzerland, for instance, you must have an insurance. It's compulsory. As soon as you get your visa to live there, they will send you a letter saying, you need to prove us that you've contracted an insurance. If not, we will pick one randomly and we'll just bill you. Of course, for people that don't have the means to pay their insurance, there is state subsidies. The deductibles are fixed, so you can choose your level of deductibles according to what you think would be your health expenditure during that year. For instance, it's very typical that women, when they become pregnant, they reduce massively their deductible because they know for a couple of years they will have more appointments than when they were not pregnant. The premiums depend on age, but not in pre-existing conditions. So this is a big difference to the US. And besides the deductibles, normally everyone is expected to pay 10% of the total cost of their expenditure up to 700 francs. So if you live in Switzerland, you know that you should have in the bank your what you select as a franchise plus 700 francs in case something happens and you need to pay. Um, and then there's free choice of insurance and deductible level, and we can change every year. Normally in December, people can select if they continue with the same insurance company or they change. This is for disease. Everything that is related to accidents, so this is quite particular to Switzerland, is paid up by the employer and there's no deductible. So depending on, sometimes in the hospitals, there's a discussion, was this an accident, was this a disease, but it's just for billing purposes. In terms of the providers, what does this mean? It means that's free choice by the insured. If ambulatory care, so people can go and see an oncologist, a cardiologist in the private practice or in the hospital, and it would all be covered by the insurance. Everything that requires admission and hospitalization is only covered in public hospitals. Whoever wants to be hospitalized in very private clinics with views to Mont Blanc and all that, they pay out of their pocket or they have an extra insurance that they can pay for that. The payment is fee for service or ACT. There is a long table, as I told you, that is negotiated between physicians, hospitals, and the insurance companies. There is a strong competition within the private sector, and there is also competition between the public and the private sector. The access to providers is very easy, as you can think. If they're all reimbursed, I don't know how many radiology clinics we have in Geneva, but of course, this also increases the risk of supply-induced demand and drives the healthcare costs quite high. So after talking to you about the Swiss healthcare system, I'll just give you 2 points about a population-based study that has been ongoing in Switzerland and from which most of the studies that I will present stem from. This is the Busanté study. It's a cross-sectional, a repeated cross-sectional study. Oh, some of it is in French, sorry. And every year there's roughly 1,000 adults that are invited to participate in the study, age 18 to 74. They are selected at random based on a list of residents in Geneva, and they are invited to come to the hospital or to the bus, so the bus that goes around Geneva to fill in 5 health and socioeconomic and other, for instance, a nutrition questionnaires and for a health examination. And in some cases, there's also blood samples that have been withdrawn. We have roughly now we have more than 20,000 Geneva residents that have participated in this repeated cross-sectional study starting from 1992. So before I go to talk about health inequalities in cancer, let me just, because we just talked about the features of the Swiss system, we asked a couple of questions that were outside of the cancer and outside of inequalities in cancer that focused specifically on the features of the Swiss system. One of the questions was, what is the association between someone choosing a deductible that is very high with foregoing healthcare and taking into consideration their socioeconomic status? So for this, again, we use data from this repeated cross-sectional study of around 11,000 participants. And what we found is that in Geneva, there's 10% of people that reported foregoing healthcare in the previous year. So despite what I told you of universal healthcare, that everyone has access to a cardiologist in 2 days, there's still 10% of people that reported foregoing healthcare. And what we've seen is that obviously, the lower your income or your socioeconomic level, the higher the impact in reporting foregoing healthcare in Geneva. So you have here deductibles that are high, and as you can see, if you are at the first income, we are around 24% of people reporting foregoing healthcare. So the higher your deductible, if you have lower resources socioeconomic, the higher the probability that you forgone healthcare. But what we see is that independently of your socioeconomic status, there is an increase of foregoing healthcare depending on which deductible you choose. And this is what we then try to estimate using adjusted models. And what this is basically what we see here. If your income tercile goes up, so if you're in the first income, if you have lower income, you will see that you have higher levels of foregoing healthcare. This lowers when you're in your third, but this gradient is there. So the choice of your deductible clearly impacts if you forego healthcare or not. And then doing these measures, as I said, of inequality, we do see that if you compare people that have low deductibles versus high deductible, you will renounce care in a bigger way if you're in this third tertile of income. So we then try to ask, what do people renounce in terms of care? And it was not so much surgeries or medication, but mainly appointments with GPs and specialists. This is probably because the prices of the surgeries are so high that normally, if you need one, you're just going to have your surgery, pay your 700 plus your deductible, and that's it. While you have more flexibility in instead of going to see your GP once every 3 months for the people that need it, they just go out once every 6 months, and this is probably where they're cutting their costs. And this, what we see is that over time there is a tendency to choosing a higher and higher deductible. So this is a problem that is still ongoing, and we will need to reevaluate it to see how it has evolved, especially after COVID. Of course, I'm telling you, people have foregone care, so they haven't gone to see their doctors, they haven't gone, I don't know, to do some blood tests, but was this needed? What was the value of this care that is foregone? This is something for which we don't have the answer in this study, but in a subsequent study, what we did is we went back and picked around 1,000 participants that had reported foregoing healthcare or not. And what we've seen is, independently of socioeconomic status, the ones that had foregone healthcare had had worse control of blood pressure, higher cholesterol, worse glucose ratings, and a worse self-reported quality of life. So my point here is that features of the healthcare system can greatly impact the use of healthcare, of the healthcare system, and these may have consequences for the population, and it's something that we would like to study forward. So after this small uh, side note, let me now talk to you about the main topic that brought me here, which is health inequalities in the cancer care continuum, with a specific focus on breast cancer. So what do I mean by the cancer care continuum? So every time we talk about cancer and oncology, a lot of the focus is on diagnosis and treatment. We have all the campaigns about we should do early diagnosis and all this push from the pharmaceutical industry and from research in finding innovative treatments. But the reality is we also have screening, which is quite important. And before that, of course, prevention. I'm talking to public health specialists or future public health specialists. I don't need to stress the importance of prevention. But besides that, as our treatments are getting better and better, we talk about survivorship more frequently. So in the case of breast cancer, 80% of the women are cured from breast cancer. Some of them do a treatment for 5 years when there is no longer the disease, and it's mainly the treatments that are causing problems in terms of quality of life. So the survivorship phase is increasingly important. And unfortunately for the patients that we don't have a treatment that can cure them, supportive and palliative care is of paramount importance. So if we go and think that socioeconomic factors can have an impact in every phase, it's not surprising that we will find inequalities in patients with cancer, not only in their survival, but probably beyond that. If we just look at data, I will present to you mainly data from Switzerland and from Geneva, except for the last project. But if we look at diagnosis and treatment, there's already enough data from Geneva and other places that show that women with lower socioeconomic status have a higher probability of having stage 3 and stage 4 breast cancer. Why? That's a huge discussion. It could be as a delay in diagnosis. It could also be because women normally with low socioeconomic status tend to be younger, so their cancers might be more aggressive. But independently of that, what we also see is that the breast cancer specific survival, according to socioeconomic level, it's higher the higher the socioeconomic level. And this is independent of stage of diagnosis. So the socioeconomic level plays a big role in what we see at stage of diagnosis, but also in the survival itself. If we now focus on prevention, just a couple of studies that we've conducted in Geneva asking relatively easy questions in which Teresa had the opportunity to work with us and us with her. One was on smoking. So first question, easy one. Are there inequalities linked to socioeconomic level in smoking in Geneva? And then we also wanted to assess what was the equity impact of the different public health interventions that took place in the canton. And we asked, so what was the impact of the 2009 smoking ban in these inequalities, meaning in smoking rates, cessation rates and prevalence? For this, again, we use data from this Busanté study, including 17,500 women between 1995 and 2014. We first checked, and what we've seen is that the introduction of the smoking ban improved the outcome, so increased the quit ratio, decreased the smoking prevalence. But as you can see, this was short-lived, probably through an adaptation of behaviors that happened in the years after the implementation of the ban. And if we ask specifically about socioeconomic inequalities, yes, they exist. Not surprisingly, as you can see, in smoking prevalence, there's 15% absolute difference in inequality. So if you compare the percentages of people that smoke in low and high socioeconomic levels, we will see that it's 50% more in absolute levels in those with lower socioeconomic level. And on the other hand, of course, the inverse is true for cessation rate. So our inequalities were present, and this were adjusted for the age, gender, nationality, and secular trends. Second question was, so what did the introduction of this ban did to these inequalities? And what we've seen is not only were not reduced, they actually increased the magnitude of these inequalities, probably suggesting that making a public smoking ban will affect those people that smoke in the public places, but those with lower socioeconomic levels that probably smoke at home were not affected for this ban. This is a probable explanation for why we see this increase in socioeconomic inequalities in smoking outcomes. If we then focus on alcohol, same exercise, can we see inequalities on hazardous alcohol consumption defined by more than 30 grams per day for men and more than 20 grams per day for women? And the second question, what were the impact of the different alcohol control interventions? There have been several packages. We defined several periods. The first baseline, the second one when advertising ban was introduced. Afterwards, in 2004, there was an increase, a massive increase in alcohol pops price and sales that were banned after 9 p.m. And finally, as we know, there is a strong relationship between smoking and drinking. What happened after the implementation of the smoking ban? Again, around 17,000 participants from the Busanté study between 1993 and 2014. And what we've seen in terms of the prevalence of hazardous alcohol consumption, the first thing that we see is that we should not analyze men and women together because the trends are completely different. As you can see here in men, there was a gradual decrease in hazardous alcohol consumption for people with secondary and tertiary education, while those with primary education, the line is flat, while in women, there's a lower consumption and the inequality gradient is not as apparent. If we just focus on measures of inequalities and what in the different periods of the alcohol control interventions, this is what we see. SII is in absolute terms, RRI is in relative terms, but basically what we see is for women here in blue, there are no inequalities. So none of the interventions also foster the inequalities, but in men, independently of what we did, of all these interventions, the inequalities were still there and they were not abrogated. So despite the fact that these interventions may have contributed to reducing the overall hazardous alcohol consumption in the population, they were not sufficient to reduce the socioeconomic inequalities that were there from the present and continue throughout the period. We may even argue if they're not increasing in relative terms. So now focusing on screening, sorry. Mammography, a used screening technique pretty much everywhere. And we ask the question, what are the mammography trends in Geneva? What we've seen since 1992 until 2014, there is a huge reduction of women that have not been screened. This coincides with the introduction of organized screening program in 1999. But what we see is that there is a hint that the gradient is still present, with in this case more screening in women with a higher socioeconomic status. So this is the percentage of women that had never been screened. These inequalities, independently of the introduction of an organized screening, persisted. So basically, the organized screening was quite important or was associated with a massive reduction in women that had never been screened, but the socioeconomic inequalities persisted. We also asked other questions because we had data on these women or where did they live. If there were spatial associations of breast cancer screening in Geneva and how these spatial clusters were associated with socioeconomic factors. We were talking about 2019 or 2018 when we talked about clusters. It was a tough explanation to say to people what we were going to do. Then COVID came and clusters became widespread knowledge. Just if you allow me to make another side note, this is just another project that we did with data from the hospital for which we had the addresses, finding where were the clusters of COVID in Geneva throughout time. Okay, it's just like a Christmas tree, not very interesting. But the interesting thing is that when we start looking at where these clusters were and what were the measures of deprivation or where these clusters were, we see that clusters that appeared in most deprived areas were the ones that persisted over time. Again, just another demonstration of how important it is. The socioeconomic status, of course, we can discuss if this is related to living conditions or related also to the kind of jobs that people actually have that might have exposed them to more levels or a persistent infection compared to others that probably work for the banking sector and were working from home and well isolated. Now, if we go back to mammography, we can do this kind of exercise and try to find the red dots, so the hotspots of non-participation in mammography, for which there is a spatial association, and the blue spots, which are the ones where there is a high uptake of mammography. And what we've seen is that in 36% of the participants in the trial, or in the trial, or in the study, there was a spatial dependence. And not surprisingly, when we adjusted this analysis for socioeconomic factors, we saw that the majority of the spatial dependence was related to socioeconomic status, but still there persisted 16% of the sample where there was this spatial associated that was not explained by socioeconomic factors. So probably there are other factors that might explain that are not only related to your income and education, like social networks or the built environment where you're living. We also made an exercise of seeing what was the distance between each person and a radiology center for screening, and we saw no association. So this is not related to access to screening. Now, if we talk about survivorship, and this is the last project I will mention, as you know, more and more quality of life is important, not only survival. And we wanted to understand if the quality of life of patients that have a breast cancer that is not metastatic, so as I said, the majority of these women are cured after treatment, if the quality of life it differs according to socioeconomic level. And of course, if this is irrespective of stage and treatment, but I'll get back to that. So also, the other question is like, if we actually see that there are inequalities in their quality of life, do they change after diagnosis and treatment? For this, we had to go outside of Switzerland and explore the data from the Canto study. So this is a study that includes women with non-metastatic breast cancer, so stage 1 to 3, from 25 French hospitals, where there is a longitudinal follow-up and for which we have full clinical and socio-demographic data. In this case, for as indicators of socioeconomic status, we use financial difficulties, income, and education, and there are more than 30,000 patients that have been included with a follow-up that is ongoing. And to measure the quality of life of women, we used a very well-validated questionnaire, the ORTCQLQC30. We can calculate a summary score. The higher, the better the quality of life. And this questionnaire was administered at baseline, so at diagnosis, 1 year after the diagnosis, and 2 years after the diagnosis. So if we just look at these women, there's almost 6,000 women, we see the same thing as I said before. The higher your socioeconomic status, the lower the probability of having, in this case, stage 3. And if you look at women with high income level, there is a clear gradient in stage 1. So we know the higher the socioeconomic status, the lower the stage of diagnosis. As we can see here, women with higher income were more frequently postmenopausal. This is normal. The older we get, the more money we get, and the lower the level of comorbidities, which may be related to age, but not only, of course. If we look at the treatments, this is more for oncologists, but what we see is what we expect. Because the stage of diagnosis is higher, the women with low socioeconomic status will have more, how can I say, aggressive treatments, in this case, chemotherapy or the ALD, which is lymph node dissection in the axilla, and less of BCS, which is breast conserving surgery, and more mastectomies. This, of course, is related to the fact that we are detecting women at a later stage if their socioeconomic level is lower. And this can have an impact on quality of life. Just a very busy plot, but quite easy to understand. This is just the average scores of this quality of life questionnaire according to socioeconomic status. In pink are the people with the higher socioeconomic status. In brown are the people with the lowest socioeconomic status. And as you can see, particularly for financial difficulties and income, the higher your income, the better your quality of life at diagnosis year 1 and 2. Of course, we can say, oh yeah, but some women were younger or others were older. The stage of diagnosis impacts a lot. So we can use regression methods and calculate what is the difference from baseline adjusted for these other factors. And what we see here is that in all cases, there is a reduction in quality of life for all women, that we know. The breast cancer treatment is not anodyne. There is a lot of side effects. But what we do see is that there's a bigger dip in women with high financial difficulties, with lower socioeconomic lower income level, and with lower educational level. So tells us that the impact of the treatment is probably not the same and depends on your socioeconomic status. If we then now try to measure what is exactly the inequalities at diagnosis year 1 and year 2, we can make a prediction of what is the gap, the socioeconomic gap in quality of life. This is what we did in the next analysis. If we just look at baseline at diagnosis, so women were diagnosed with breast cancer, and we just say, well, it's not at the same point, but at baseline, we made them a quality of life questionnaire. And what we see is that there are already inequalities in quality of life. This is expected. The higher the socioeconomic status, the better our standards of living, the better our quality of life. And what we see is that when we go to year 1, there is a significant increase in this gap. And when we go to year 2, when the majority have finished their treatments, their chemotherapy, their surgery, some of them are on endocrine therapy, this persists. So this is not just a moment in time when you receive your chemo, this is something that persists throughout time. Of course, these analyses, as I've said, were adjusted, particularly for staged diagnosis and which treatment they receive. So this is independent of which treatment you receive. It's not only a reflection that women with lower economic status have worse cancers. There's something besides that or beyond that. Again, in other groups, we've seen that this is true for premenopausal and postmenopausal women, independently of which treatment the patients got, we still see the same trends. So to sum up all this presentation, socioeconomic inequalities can affect the entire continuum of breast oncology care, and I would argue of all cancer care. In addition to incidence and survival, I think it's important to focus on quality of life because most patients are actually cured of their cancers. So what the sequels that they have, the impact of long-term quality of life is quite important. These are independent of stage and treatment received. It's not only that we are detecting more aggressive tumors in people with lower socioeconomic status. This is why they suffer more. No, it's beyond that. And they are found in places with a good healthcare system, with Switzerland, with a very high income country, and in countries with a strong welfare state like France. When we started, the French were not very convinced that we would find these inequalities, and I was sure we would find them, and we found them. When we presented these results in the States, they said, "Oh my God, if this happens in France, what happens in Texas?" And I said, "Well, that's for you to tell me." And inequalities in oncology are increasingly recognized as important. Academically, we were able to place this study and publish it in a very good oncology journal. I don't know if that will be possible today after the change of the US administration, but let's see. In practice, I think it's important to continue to detect, measure, and monitor these inequalities. And for those that follow the oncology world, we keep on talking about personalized care, identifying the right gene to give the right treatment, and sometimes with very small benefits overall survival. When we actually see that socioeconomic level, it's a main determinant in the outcomes and in the quality of life of patients. So this should be capital in terms of how we manage our patients and should not be neglected as it is at the moment. So to finalize, I would just like to acknowledge everyone that I worked on throughout the years in different projects in Geneva with Idris Gissous and Sylvie Strangini that some of you may know, all my colleagues at the oncology department, and Teresa, that I have to tell you that I was an oncologist, and the reason why I did inequalities was talking with her several times and hours, and I said, this is quite interesting. So I have to thank her for being at the genesis of my interest in socioeconomic inequalities and also for her collaborations and contributions to some of these projects. I'm open to any question concerning any imprecisions on my slides or any other questions you may have concerning this data, Switzerland, or whatever you may want to ask me. Thank you very much for your attention, and I'm looking forward to your questions.